Hello, welcome to this program titled Patient-Centric Approach to Utilizing Oral SERDs for ER-positive HER2-negative metastatic breast cancer after first-line endocrine therapy. I'm Aditya Bardia, medical oncologist at UCLA. Joining me today are Kevin Kalinsky.
Hi, everybody. Thank you, Aditya. It's good to see everybody. I'm a professor at AMA University, Winship Cancer Institute. It's great to join you guys today.
And Leslie Fallowfield.
Hello, everybody. I'm a professor of psycho-oncology at Brighton and Sussex Medical School, and again, really interested in this particular topic.
Right. So we have a global panel today, and we're very excited about the discussion. Today, we'll review the need and importance of oral SERDs as second-line treatment for patients with ER-positive, HER2-negative metastatic breast cancer. In the next 30 minutes or so, we'll cover first-line management of ER-positive metastatic breast cancer, approach to second-line management and treatment algorithm, biomarker testing, approved SERDs and emerging agents, and then finally, management of side effects, as well as patient-centric communication strategies to increase adherence and persistence to therapy. During this session, please feel free to write in your questions and we'll address them during or at the end of the program. Just send in your questions. So let me first start with the first line management, and I'll ask Kevin. Kevin, can you go over the first line management for a patient with ER positive metastatic breast cancer? What's your approach?
Sure. I think about a few things when deciding what therapeutics to consider first line. So for instance, if patients have endocrine sensitive disease, and by that I mean, might have received hormonal therapy in the operable setting, if they did not have a tumor that had recurred within, a year of completion of their operable therapy, oftentimes we're utilizing agents like aromatase inhibitors for our patients. If patients have endocrine resistant disease, meaning it recurred while on an aromatase inhibitor or shortly thereafter, often within that 1 year time period, then sometimes we think about utilizing fulvestrant, which is an intramuscular selective estrogen receptor downregulator. And for our patients, we are often utilizing CDK4/6 inhibitors in combination with these endocrine approaches, just given that we see this improvement in median progression-free survival across all of the studies, and a number of them showed an improvement in overall survival as well. And I was just thinking about how back when I was a fellow a long, long time ago, how for our patients that we were worried about, if they had visceral disease or quote unquote impending crisis, visceral crisis, or they were very symptomatic, it used to be we would start these patients with chemotherapy. But we've even seen from studies like the Right Choice study that giving combination of hormonal therapy, CDK4/6 inhibitor was better than giving doublet chemotherapy. And it just is highlighting the evolution of how we treat these patients in the frontline setting.
Absolutely, certainly changed over time, and CDK4/6 inhibitors have become the preferred combination therapy with endocrine therapy in the first line setting. And because pretty much everyone gets a CDK4/6 inhibitor unless there's a concern that there could be difficulty in tolerability with a CDK4/6 inhibitor. And I fully agree with you. In general, even with patients with a lot of visceral disease, I tend to use CDK4/6 inhibitor. The only time I've used chemotherapy is if a patient has visceral dysfunction, when it is not safe to use a CDK4/6 inhibitor like elevated bilirubin or creatinine. But outside of that, it's CDK4/6 inhibitor.
Yeah.
So
I totally agree with that. The other point just highlighting is the responses, right? The responses we can see with hormonal therapy and CDK4/6 inhibitors in that 50 to 60% range, it can be quite active.
absolutely, which was a concern with endocrine therapy alone in patients with a lot of visceral disease, that it might work, but it could take time and you want a quick response. but we see that with a CDK4/6 inhibitor. Any thoughts on choice of CDK4/6 inhibitor? We've seen some differences in PFS and overall survival.
I would say that in general, I'm utilizing ribociclib given that we have 3 large studies with an improvement in overall survival. There's a lot of controversy about this because, we don't have follow-up in the control arm that's the same across all studies. Some of the studies are smaller than others. And so I tend to use ribociclib, though I will also say that sometimes it's dependent on the patient, right? If it's a patient that I'm concerned about drug-drug interactions, or a patient has a prolonged QTC, I have concerns about ribociclib. If a patient has neutropenia at baseline, I may be concerned about palbociclib or ribociclib and utilize abemaciclib. So it can be a little bit dependent. But I tend to utilize ribociclib as the preferred agent now, just with the studies. What about you? Do you have a similar approach?
Absolutely, a similar approach, given the improvement in overall survival we've seen. But if need to use palbociclib, that could certainly be used in this setting. So that's a good segue into second line management. Let's say you have a patient, first line ER positive metastatic breast cancer, de novo metastatic disease, receives, say, letrozole plus palbociclib in the first line setting, and then 2 years later has disease progression. What would be your approach to the second line setting, including continued use of CDK4/6 inhibitor? Kevin, you've done research in this area, the maintain study, and there are other studies as well. So could you go over your approach?
Sure. I mean, I think you highlighted that this patient was on their CDK4/6 inhibitor and hormonal therapy for 2 years. I think that is informative. It shows that the patient has had some endocrine sensitive disease. I do think, consideration of sites of METs, size of those sorts of things are part of the consideration. And, this is an ever evolving field. We have data with single agent elacestrant in those patients who have an ESR1 mutation. And there is particular benefit for those patients like this who are on their hormonal therapy and CDK4/6 inhibitor for at least a year. We also have data for patients who have alterations in the PI3K/AKT pathway. We have fulvestrant plus capivasertib for patients who have a PIK3CA or AKT mutation or PTEN alterations. We've had alpelisib for patients specifically with PI3K mutations. And then there's this question, Aditya, that you raised about continuation of a CDK4/6 inhibitor. And this has been a field for which up to this point, we have seen really phase 2 trials. We have 2 phase 2 trials of continuing palbo after palbo, but switching the endocrine therapy at the time of progression. And those did not show a benefit of continuing palbociclib. We have the maintain study, which was essentially the majority of those patients, about 90% of patients, switched from palbociclib to ribociclib, and there was this improvement in progression-free survival that was seen. But what we're really waiting for are the results of randomized phase 3 trials, like the post-MONARCH study, as well as EMBER-3. So in post-MONARCH, patients were randomized to fulvestrant with or without abemaciclib directly after progression on an aromatase inhibitor and a CDK4/6 inhibitor. And then we have EMBER-3, which is a 3-arm study, which is essentially looking at fulvestrant or imlunestrant, which is an oral SERD, versus the combination of imlunestrant plus abemaciclib. And those are the studies that I think are really going to define this question about CDK4/6 after CDK4/6 inhibition. And both have been completed and hopefully we'll be reading out relatively soon.
Yeah, and I'm looking forward to seeing the results of those studies because that would potentially further refine our approach in the second line setting. And we've seen the positive maintain study, but there's another study, the PACE study, just recently published in JCO that was negative. Any thoughts as to why there's discrepancy between the studies?
Yeah, I mean, I think one of the observations in that study, in the PACE study, is there was a difference in the control arm. And so that's really something to keep your eyes looking for in these various post-CDK4/6 inhibitor trials, where you look at the control, in PACE, the control did better. So these patients overall seem to have more endocrine-sensitive disease and maintain. The control arm did worse. There was a delta of about 2 months or so. The other interesting thing in PACE was there was a third arm of giving fulvestrant plus palbociclib plus avelumab, which is a checkpoint inhibitor, and numerically that triplet seemed to have some real benefit. And there's some data that we have about CDK4/6 inhibition, increase in T cell infiltration. It's hypothesis generating, but it was really quite interesting. And so, Aditya, I wonder about your thoughts in this post CDK4/6 inhibitor world, and how you think about the specific agents that you use as that next line, and incorporation of biomarkers, and whether you always are checking circulating tumor DNA at the time of CDK4/6 inhibitor progression. Do you check it earlier? Just curious about your approach incorporating those assays.
Absolutely. And I think the field has evolved over time. In the past, we were using first line CDK4/6 inhibitor, and the question was, should we continue the CDK4/6 inhibitor? In general, if I do that, I would switch the type of CDK4/6 inhibitor, but eagerly looking forward to post monarch results, because that would be very informative in terms of management in this setting, given that we often use ribo and sometimes palbociclib in the first line setting. So if you have to switch, you usually would like to go to abemaciclib. But the field has moved on to biomarker testing. I think in the second line setting, we need biomarker testing to guide therapy selection. Often plasma-based genotyping is used, to your point, Kevin. That's what I use routinely, because it's easier for patients when we do blood-based genotyping. And second, you can do it serially, which can be helpful to identify acquired alterations, which can be missed by just doing sequencing of the primary specimen. For example, ESR1 mutations can be missed if you just sequence the primary specimen. So that's why I tend to like plasma-based genotyping. And it is actionable. If a patient has detectable ESR1 mutation, you could consider elacestrant as the standard of care therapy. If a patient has PIK3CA mutation, there are two drugs that are approved in that setting. One would be alpelisib with fulvestrant. The second would be capivasertib in combination with fulvestrant. If a patient has alterations in the AKT pathway, which includes PIK3CA mutation, but would also include AKT mutation as well as PTEN mutation, in that setting, we would use capivasertib. And if a patient has detectable germline BRCA mutation, the use of a PARP inhibitor. So it's very actionable. Whenever we order a test, it's always like, what would we do with the results? Here, it is actionable, and based on the results, we can do therapy selection. So that's why I tend to do that. Leslie, any concerns with biomarker testing, obtaining that, in this setting?
Well, obviously, one of the primary difficulties I think here is that patients will hear about all these new drugs, and actually trying to explain the rationale, the logic as to why one of the drugs that Mrs. Smith down the road actually had isn't appropriate for them is quite difficult in a clinic setting, when patients are naturally rather fearful about what lies ahead. I think biomarker testing is going to become so routine because it's also so much easier to do now. And hopefully what we'll see is that patients get much more beneficial results from because we're matching treatment more appropriately to them. But I think actually the explanations, as I say, for rationale and logic for different treatments is quite a test, given all the other things you've got to talk about with patients.
Absolutely, absolutely. And this was, theory in the past is now practical. Let's say, future is now in terms of precision medicine and choosing these therapies. So let's continue the story. This patient who, received CDK4/6 letrozole first line, worked for 2 years, then had disease progression biomarker testing, which showed a mutation in the estrogen receptor or ESR1 mutation, and no other mutation was seen. So, what would be your approach in the second line setting, Kevin? And can you review the approved as well as emerging oral SERDs?
Sure. So, there have been, when we started this conversation, I talked about fulvestrant, which is a intramuscular selective estrogen receptor downregulator, or SERD. There are a number of oral SERDs that are in development now. Right now, at this moment, in April 2024, we have one approved oral SERD that is elacestrant. That approval is based upon data that Aditya has presented and published that looked at giving elacestrant versus physician choice endocrine therapy. So this was a randomized study in which a good proportion of patients had received prior CDK4/6 inhibitors. And what was seen was that there was this improvement in median progression-free survival. And that improvement seemed to be, most notable in patients with ESR1 mutations, which has led to the approval specifically in those with ESR1 mutations. And elacestrant is, as you mentioned, commercially available. It is a drug that does not have some of the toxicities that we see with other agents like aromatase inhibitors. For instance, we do not see arthralgias with this particular agent. And just to go back to efficacy, some intriguing data that were then presented at San Antonio Breast Cancer Symposium in 2022 demonstrated that those patients who were on their prior CDK4/6 inhibitor and endocrine therapy for at least 12 months, similar to the patient that we're discussing here, seem to have the greatest delta of benefit. For instance, patients who received elacestrant in that cohort of patients, had a median PFS of about 8 months or so compared to physician endocrine therapy, which was about 2 months. So that's when we really start to see this delta of benefit really demonstrating that these patients have endocrine sensitive disease. And I will say for me in my clinic, when I think about utilizing single agent elacestrant, because we do not right now have safety or efficacy data giving elacestrant in combination with other targeted therapies, I do take into consideration that 12-month period. Though that's not specifically something that's in the label, but something that's still clinically relevant for me.
Absolutely, that makes sense, especially with a median PFS of close to 8 months. That's impressive and clinically meaningful as well. So very reasonable to consider that surrogate marker. And you brought up the point about combination therapy. While we don't have safety data with combination, sometimes when we do plasma-based genotyping, we do see coexisting mutations. So, for example, if this patient had ESR1 and PIK3CA mutation, how would you approach that setting?
Yeah, I think that this is such a hot topic. I was actually going to ask you the same question, but I will answer the questions since you'd asked me first. The way that I approach this, and I really am curious about your thoughts about this. One I will say at San Antonio this past year that there was some continued evaluation from Emerald where they looked at patients who had PIK3CA mutations, and there was still a benefit of elacestrant compared to physician endocrine therapy. Physician choice endocrine therapy. And I will say the way that I think about it now is if I have a patient who was on for at least a year of their prior CDK4/6 inhibitor, I take into consideration the extent of their disease. If I need a little bit more bang for my buck, I may use something like fulvestrant in combination with capivasertib. But if a patient has relatively slow, indolent disease, bone-only disease, and again, has been on for, their hormonal therapy and CDK4/6 inhibitor for at least a year, then I may think about giving single-agent elacestrant. That's at least how I'm thinking about it now. We do not have cross-trial comparisons, so that's how we have to utilize our clinical judgment. But Aditya, I wonder if you think about that similarly, or if you tend to favor one compared to another in terms of approach.
I agree because previously we didn't have data, but at San Antonio Breast Cancer Symposium 2023 we saw biomarker results from Emerald, which showed that even patients who have both ESR1 and PIK3CA mutation, if the prior duration of CDK4/6 inhibitor was more than 12 months, in that setting, elacestrant provided benefit with median PFS that's comparable to what we've seen in other studies. So I do feel comfortable using elacestrant in that setting. And it's a matter of using these drugs in sequence. If you start with elacestrant, then after that, you can do fulvestrant alpelisib or some other approach, fulvestrant capivasertib in this setting. So let's say that's what the patient received. So the second line setting, the patient started elacestrant. The question now is, what are the common side effects with elacestrant? How do you manage the quality of life? Maybe I'll start with you, Leslie. Your thoughts on side effect management and quality of life with these oral SERDs?
Well, I mean, at the moment, of course, I'm not convinced that we've got sufficient reliable data from some of our trials. We've certainly had most other hormone treatments available for years, and we now know what the profiles are. And everything sort of new initially doesn't look too bad. And it's only, I guess, when you've been using things in clinic for a while that you start to see things emerging. We never realized, for example, that arthralgia was a big problem with AIs until quite a long time through all the trials. I guess sort of one of the things, though, that's really, really important here is that you've been talking a lot and quite rightly about the, sort of benefits of the new therapies that are available to us. But of course, they're only going to be useful if they actually are ingested by the patient. They don't stay in the bottle. If they stay in the bottle, nobody's going to benefit. And one of the things I worry a little bit about, given that we know side effects and unaddressed side effects really do reduce adherence, one of the things I worry about is that patients who are in a clinical trial setting are rather different from people outside of clinical trials. And we know from lots of work that's been done that particularly our older patients are on truckloads of other drugs, polypharmacy. They don't get anywhere near a trial. And the more drugs that people are taking and the more oral drugs that people are taking, the less likely it is that they will adhere to the drugs that you really want them to take. We know that dosing, for example, has a big effect on people. If you're only taking a drug once a day, you're more likely to adhere. But how often do you in clinic ask people about polypharmacy, how many drugs they're taking, and whether or not they ever forget or choose not to take them?
That's a great point. That's a great point, especially given many of our patients are on multiple drugs, and it's important that it's almost like prioritization. If you're unable to take all the drugs, don't forget the ones that are really important.
That is so, so important. And I really wish I could hear more clinicians say that to patients, because a lot of patients I talk to, they pick and mix a bit. Well, on Thursdays, I take the little blue ones, and on Wednesdays, I take the red ones. And I mean, also, I don't think we recognize the many burdens that are associated with the different types of drugs. When I ask clinicians what size drugs are, for example, do you know what the size of bisphosphonates are like? Oral bisphosphonates, they're like horse pills, and patients don't take them regularly. So I think if we're going to really, really see benefits of all these new treatments, we've got to first of all address polypharmacy, check what patients are on, and actually we can take some patients off some of these drugs because they're not often monitored sufficiently. We need to help educate them a little bit about which ones are really, really important, and actually address the side effect profiles that they are experiencing. Vasomotor complaints are the primary reason why in a chemoprevention, an adjuvant, and an advanced setting, women don't take endocrine treatments. And despite the fact that, we don't like fulvestrant, although, for all sorts of reasons, at least you knew it was going into the patient. Whereas the new oral SERDs, we've got to really work hard to make sure that patients take them.
Yeah, yeah, it's a good point, and it's almost like, show me the pill in terms of knowing what the pill size is and the frequency is. These are all, important considerations.
So,
So to wrap this up, I'll just mention the question of, say, the patient starts elacestrant with the most common side effect is nausea. Usually does not cause other side effects like bradycardia or visual disturbances, which are seen with other oral SERDs. But
yes.
a month later, the patient comes in and is complaining of nausea. So, Leslie, what are the strategies to help with compliance and these communication strategies that you've been talking about?
Well, I think it's very important to, first of all, acknowledge to patients that side effects are very important to report to you. We know that if you warn patients about the potential for different side effects, they're more likely then to report them to you, and they're more likely to adhere if they know that the reason you want them to report them is that sometimes we can do something about it. So I think one of the most important strategies is always to say to patients, look, we're really excited about these new drugs. We do think they're going to give you all sorts of benefits. But the downside is, of course, with anything, that some patients do have certain side effects. So it's really important you tell me or the nurse every time you come along what is actually causing you problems. It might seem insignificant, but we can always find something that we might be able to offer you. That way, it's more of a collaborative discussion between the patient and the doctor. The patient isn't scared that you'll just take them off the drug because there might be something that can help. And it means they're more likely to not just adhere, but persist for the treatment time that you actually have recommended to them. I think also we know that sometimes actually having, if you've got a specialist nurse, to call the patients up regularly and ask them if they're having any problems with taking the drugs so that we can help. I think it's stressing the positive. Sometimes I think a clinical scientist gets very excited about the benefits and underestimates the toxicities that will affect adherence.
Absolutely. And these become really important considerations as these drugs are moving to the adjuvant setting, where compliance, adherence would be a key determinant of success. You would not benefit from a drug if you don't take the drug. So, thanks
So
so much.
I wonder if I could just say, actually, just a couple of extra things, which is that I always think it's a useful thing to say to patients, how easy do you find it to swallow pills? That's a key question. And also then to say, sometimes patients tell me that they forget to take them. Does that ever happen to you? And that can segue quite easily into, do you sometimes choose not to take them? It's a complicated area, but I'm sure we could do better at it.
That's a very good suggestion and very non-judgmental as well. Showing an example that patients tell me this. Has this happened to you? But that can help address that question. Excellent. I'll remind the audience again, if you have any questions, feel free to send in your questions using the chat function. As you're thinking of questions, maybe I'll start with the first one to Dr. Kalinsky, and that's with the different oral SERDs, maybe with elacestrant. Have you used the drug, and how's your experience been with elacestrant?
Yeah, anecdotally, it has been the side effects that we've seen have been what we've discussed has been, gastrointestinal issues, potentially nausea. We've not seen photopsia, as you'd mentioned, that we can see with other oral SERDs that are in development. No cardiovascular issues in particular. What I mean by that is QTC alterations, and so I would say that it's been tolerated. Again, we've been giving it as single agent. And really been particularly used in those patients who are on their prior endocrine therapy and CDK4/6 inhibitors for at least a year.
That's great. Great to hear. And as these drugs, again, move to the adjuvant setting and adherence compliance even becomes more important. Leslie, are there any additional strategies to improve adherence? Any screening tools that providers can utilize?
Yes, actually, there are quite a few good things that you can use in a clinic. There's something, an 8-item screening tool designed, it's called Make Medicines Work For You, but it actually, these 8 questions allow you to predict really with quite a degree of accuracy who's likely to non-adhere. And I guess you don't have to be a behavioral scientist to recognize that in an adjuvant setting, the first thing that a patient will experience when they're taking their drugs are side effects. The benefits are very distal and might not ever be realized. So the proximal side effects, experiences are going to influence whether people take things or not. So always probe and ask people and remember to address their side effects.
That's a great point. In the metastatic setting, you can look at scans, you can look at tumor markers, but in the adjuvant setting, you
Yeah.
don't see the efficacy, but you do experience the side effect.
Mhm.
It's great. We're right on time. This was a excellent discussion. Thank you, Kevin. Thank you, Leslie. Thank you all for participating in this activity. I hope you found this helpful. Feel free to reach out if there are any questions. You'll find useful tool and resources on the right-hand side of this page. Thank you again for joining today.